Everybody. Welcome to another online COVID-19 webinar presented to you and brought to you by the National Institute for Occupational Health, the NIOH. My name is Ashraf Raycliffe, the National Health and Safety Training Manager. And today's topic for our webinar is COVID-19, long COVID, and the workplace. And thanks to our colleagues in the occupational medicine section, who's done quite a lot of hard work in order to get the group of presenters who will be sharing their presentations with us today on the topic of long COVID. So greetings everyone, and welcome to all of you on behalf of the NIH, the National Institute for Occupational Health, a division of the National Health Laboratory Services and a sister division of the National Institute for Communicable Diseases, to another one of our COVID-19 webinar series. We're delighted to have you on the webinar as we discuss the complex issue of what is coined long COVID, so-called long COVID. According to the Center for Disease Control, the CDC, long COVID is a range of symptoms that can last weeks or months after the first being infected with a virus that causes COVID-19, or can appear weeks after the infection. Long COVID can happen to anyone who has had COVID-19, even if the illness was mild or had no symptoms. People with long COVID report experiencing different combinations of symptoms. This certainly has implications for the workplace. However, I will stop there and welcome the distinguished speakers, Dr. Murray Dryden, Dr. Washila Jassat, who would be combining for the first part of our webinar. And the colleagues needs no introduction on this particular platform. And then there's Dr. Neil van Tonder and Dr. William Kleynhans, who will shed some light on the topic for us as well. So we acknowledge how busy you all are as presenters and as attendees, but we clearly need to ensure that we build capacity and strengthen our abilities to deal with the issue of the COVID as an occupational issue, as well as the implications and other challenges that comes with it, both long COVID, chemical or other side hazards, additional hazards and issues to deal with. So thanks again to the occupational medicine section of the NIH for leading and organizing on this particular topic, in particular Dr. Dr William and her colleague Dr. Nompumelelo Ndaba. So colleagues, we trust the session will be informational for you and assist you with your decision making and ensuring that we make our workplaces as safer and healthier environments, even within the current challenges we face. So may we have a productive session today, and take care. And before I introduce to you our first set of speakers, a few just virtual house rules. For all of you as attendees, your microphones and video, as well as sharing facilities, have been not activated. We will be having, I think, too large a number of people to have any direct conversations and or have any direct responses. The hand raising function is also not available for you. Please don't use that. We have one person there, I think as Mokove Muladzi. Please, if you could just lower your hand and type any general comments or issues you have in the chat box. That's general comments and general questions you have in the chat box. If you have questions specifically for our presenters, please type your questions for the presenters in the question and answer box. That's where the questions will be answered. So a reminder, please do not raise your hand. That unfortunately we cannot entertain when we have up to almost 1,000 potential participants and attendees of this long COVID topic. Having said that, I'm now going to look at the program itself. So long COVID, global and South African data. What is it? Clinical presentations and challenges with diagnoses, literature, methodology, and global stats, in particular South African statistics. We are going to have Dr. Murray Dryden, medical officer and emergency outbreak response unit and member of the DATCOV hospital surveillance team at the NICD. And he and his partner, Dr. Washila Jassat, have prepared this particular input for us. Dr. Dryden will be making the presentation on behalf of the team. And what Dr. Washila Jasad is a public health medicine specialist and coordinator of the DATCOV hospital surveillance team, also at the NICD. Our second input is on the impact on the workplace and considerations for fit for work certification. And Dr. Neil van Tonder, who is the eHealth occupational medicine consultant, will deal with that topic. And then finally, before closure, we will have the topic management of COVID-19 in the workplace, designing a workplace program, Dr. William Kleynhans, who is an emergency physician. So with not much ado, I'm going to ask Dr. Murray Dryden on behalf of himself and Dr. Washila Jasad to just share their PowerPoint presentation and check on audience on. In the meantime, I'm just going to do the quick brief bios that I have for Dr. Murray and for Dr. Jasad. Dr. Murray Dryden is a medical doctor who has been with the National Institute for Communicable Diseases since February 2020. The NICD is a sister institute of the NIH that is bringing you the webinar. Dr. Murray is based within the NICD, where he's part of the outbreak response unit and assisted with the clinician support, assisted with the clinician support throughout the COVID-19 pandemic. Dr. Dryden joined the DATCOV hospital surveillance team in October of 2020 and has led the NICD long COVID/PACS PASC project since then. The joint presenter there in terms of preparation is Dr. Washila Jasad. Is a medical doctor with a specialist qualification in public health medicine. She has experience in clinical practice, research and management in the South African public health sector and has a strong interest in health systems, particularly the effective implementation of health programs. Washila has been employed, Dr. Jasad has been employed by the National Institute for Communicable Diseases, the NICD, since March 2020, where she has coordinated the hospital surveillance for COVID-19. Dr. Jasad is currently registered towards a PhD focused on health policy implementation at the School of Public Health at the University of the Western Cape. And with those two relatively brief introductions and bio sketches of Dr. Dryden and Dr. Jasad, I'm going to ask Dr. Dryden to share the presentation slides on behalf of his team. In the meantime, a reminder to everybody, please, your general comments, if you could just add those general comments for us in the chat box. That is the chat box at the bottom with the single bubble. And for those who have specific questions for our presenters and the content of their presentations, please type your questions for the presenters in the question and answer box. We also have a group of occupational medicine section colleagues who's going to assist as panelists to help answer your questions in support of our presenters. I will be asking our presenters to monitor the question and answer box so that we can do some summary trends of questions at the end, subject to availability of time. So once again, welcome to this COVID-19 webinar brought to you by the NIOH. The topic today is long COVID and the workplace. So just to check, Dr. Dryden, your audio, is it okay?
Hi, can you hear me?
Yes, perfectly. Thank you very much. And I can see your slides maximized. I'm immediately going to hand over to you, Dr. Dryden. Please proceed.
I think Dr. Jasad just wanted to say a few words before we started.
Thank you. Thank you for the invitation to be with you today. And thank you especially to the NIOH for placing long COVID on the agenda. I think we've been so consumed for the past year with the acute management of COVID-19 in our health services that there's this, phenomenon that we are going to be confronted with in a bigger way coming very soon. And I think it's a good idea that we think about it and talk about it. We acknowledge that there's not a lot that we know about it yet. Guidelines are evolving, and we are currently working with the National Department of Health to think through what management of long COVID might look like, within our health services. So I think that this is a really great opportunity for us to share with you a little bit about our study. Just as background, the NICD developed a hospital surveillance program called DATCOV in March last year. Initially, it was set up as a sentinel surveillance, and then by July, it got adopted by the National Department of Health as a national surveillance system. And we now have coverage of all 641 public and private hospitals in the country, reporting hospital admissions to DATCOV. We have had over 250,000 admissions reported and over 50,000 deaths. And it's allowed us to do a lot of really important analysis for the country. But we recognized mid last year that we also needed to start looking at long COVID. And, that's where the study came from. So Dr. Murray Dryden has been leading, and I'll hand over to him to take you through a bit of the literature and a little bit about what our study, how our study is designed and what we found based on early follow-ups. Over to you, Murray.
Thank you, Dr. Justin. Go ahead with Dr. Murray.
Good morning, everyone. I'd like to welcome you all and introduce myself. As everyone said, my name is Dr. Murray Dryden, and I will be presenting on behalf of the NICD and DATCOV team on post-acute sequelae of SARS-CoV-2 infection, or PASIX, formerly known as long COVID. So let us start off with some terminology from the National Institute for Health and Care Excellence in the United Kingdom. Acute COVID is defined as the presence of signs and symptoms from onset of initial symptoms up to 4 weeks. Ongoing symptomatic COVID occurs between 4 to 12 week period following the initial symptom onset. Post-COVID syndrome is defined as persistence of symptoms for more than 12 weeks, not better explained by an alternative diagnosis, whilst the formal definition of long COVID includes both ongoing symptomatic COVID-19 from 4 to 12 weeks and post-COVID-19 syndrome where symptoms last longer than 12 weeks. Recently, the National Institute for Health in the United States have proposed post-acute sequelae of SARS-CoV-2 infection, or PASIX, as the formal name for long COVID. Just a little bit of background information on long COVID. It was initially described by patients who called themselves long haulers, and the first mainstream publications in media were out as early as February of 2020. There were predominantly stories of patients reporting persistent symptoms months after the initial acute infectious period with COVID that were being shared on blogs, Facebook groups, and other social media platforms. These patients were scared. They didn't understand why they felt ill, and even after testing negative, and importantly, they didn't know if they were still infectious to their friends and family. Unfortunately, healthcare systems across the world were very busy trying to manage the first and second waves, that our initial response was poor, and there has been significant delay in starting to deal with some of these patients. These are just a few of the PASIX support groups on the internet, as well as some of the very first articles that were published in mainstream media. And so how much do we know about PASIX? In truth, not a lot. A brief search through PubMed, you do struggle to find many articles exclusively related to PASIX, and ultimately, we do need more evidence, and particularly that which is relevant within the South African context. PASIX has thought to have arisen as a result of inflammation and injury that occurs during acute infectious period of COVID-19 disease, and these injuries can occur in all organ systems, including the brain, heart, and lungs, to name a few, but it's important to take in consideration that ultimately it may have the potential to affect every organ system in the body. Most importantly to date, there's no evidence to suggest that PASIX is the result of persistent infectious period. It is thought that these patients cannot transmit their symptoms to others, and PASIX is not considered to be a communicable disease. The most common symptoms reported initially were severe fatigue, shortness of breath, persistent cough, chest pain or heaviness, joint pain or swelling, whilst other important symptoms being cognitive impairment, muscle pain, and headaches were also included. PASIX is also often accompanied by anxiety and depression, which may be associated with a protracted and unpredictable course of these symptoms. When we looked at 9 studies who reported the prevalence of 1 or more persistent symptoms and follow-up interval between 1 and 7 months, there were a higher rate of persistent symptoms than initially reported. And we can see again that fatigue and brain fog or cognitive impairments, anosmia and dyspnea all feature rather prominently. Please bear in mind that these figures are purely ranges that were reported. As you can see, some studies did not report on all of the symptoms, and it is important to consider the time frame as well as the relative population groups within these studies, as well as the respective objectives within the studies before making any significant assumptions. With regards to diagnosis of PACE6, there are currently no laboratory tests available that can be used to diagnose it, and antibody testing is not a translatable or reliable test in making the diagnosis. PACE6 is primarily a diagnosis of clinical nature and on the basis of exclusion, so it is important to consider other conditions that may present in a similar manner. Currently, patients who are with a laboratory confirmed diagnosis with persistent symptoms beyond 4 weeks of acute illness can be considered under a PACE6 diagnosis. In addition, patients with COVID-like illness without a confirmed laboratory test but persistent symptoms in keeping with acute COVID and PACE6 may also be considered. Early data found that approximately 10% of patients infected with the SARS-CoV-2 will go on to experience PACE6, although on the previous slide, the prevalence was significantly greater than 10%. It is important to bear in mind that many of these patients experience moderate to severe disease requiring hospitalization, and statistics regarding hospitalized and asymptomatic patients are not readily available. That being said, severity of the disease has not been found to be a reliable indicator of whether a patient will develop PACE6 or not. And early data on at-risk groups have suggested that pre-existing depression is associated with severe COVID fatigue. Early research suggested that males are twice as common than females to develop PACE6, although there is conflicting evidence in more recent research, and we may need to consider health-seeking behavior between these two sexes. High BMI has also been found to be a risk factor associated with development of PACE6. Haverall et al. In Sweden performed a study with healthcare workers who had mild COVID disease. They found that 8% of their sample population had experienced disruption of their work life due to persistent long-term symptoms, whilst 15% reported symptoms moderately or markedly disrupted their social life, and 12% reported disruption of their home life. Garrigies also looked at hospitalizations and found that 47% of their sample had been previously economically active, and only 69% of these patients were able to return to work after the acute illness, whilst 31% had not. In terms of social activities, 28% of patients were unable to resume normal levels of activity, and of the 72% who had been able to, nearly half could only do so at a lower level than they had before they became ill. There was no statistical significant difference between ward and ICU groups, but there was a non-significant trend towards a proportion of patients returning to work amongst ICU patients. Finally, Carvello and Schneider found that 20% of patients were booked off work 1 month after their discharge from hospital, and a further 10% were still on sick leave at 2 months discharge. These are only 3 studies we have found so far that have described the impact of socioeconomic functionality following acute COVID disease, but we have no doubts that there are more studies with similar results to come. So next, I'd like to introduce the NICD long COVID PACE6 study, which we're currently working on. The study design is a quantitative longitudinal cohort, which will form part of the ISARIC international cohort, where 10 countries are contributing to data on PACE6. We hope to establish the presence of long-term complications of COVID-19 survivors in South Africa and guide their rehabilitation. And we'd also like to characterize the physical and psychosocial consequences in patients post-COVID infection and estimate the risk of and risk factors for PACE6. We have received ethical approval from the University of Witwatersrand, and we are proudly funded by the Bill and Melinda Gates Foundation. We are currently only sampling patients who are hospitalized and subsequently discharged alive, and we utilize the DATCOV hospital surveillance data to identify potential participants, and our research assistants and surveillance officers conduct telephonic interviews at 1, 3, 6, and 12-month periods using a case reporting form consisting of 120 questions, looking at presenting symptoms, ongoing symptoms, quality of life tools, and changes in employment, as well as the ability to perform activities of daily living. Since January of 2021, we have performed over 4,000 calls with an enrollment rate of 24%, and the median time from discharge to first follow-up is 28 days. The median age of our participants is 52 years with an almost equal distribution between male and female patients, and more than 76% of patients over the age of more than 76% of our participants are over the age of 40 years, with 59% of participants aged between 40 to 64 years of age. The breakdown of race is comparable to what you see in the DATCOV hospital surveillance data, with Africans the highest number of enrolled persons, followed by whites, coloreds, and Indian populations. With regards to patients who followed up in the study, nearly 35% presented with a history of high blood pressure and almost 25% with a BMI greater than 30, followed by type 2 diabetes just below 20% and HIV at 6%. These are the symptoms that patients reported when they were admitted to hospital during the acute phase of the COVID infection. The most common symptom reported was fatigue and malaise, just above 60%, followed by shortness of breath, cough and fever, muscle aches, headache, chest pain, and joint pains. In terms of the number of persistent symptoms, we found that 32% of patients reported that they had no persistent symptoms. In total, from our cohort of 1,061 patients, 68% of patients reported that they are still experiencing persistent COVID-related symptoms 4 weeks after discharge from hospital. From this total, 28% reported 4 or more persistent symptoms, which is somewhat concerning, and the range of symptom onset to follow-up is variable, with analysis pending on that. With regards to the symptoms reported by patients at month 1, follow-up, shortness of breath again featured with nearly 35% of the total sample, followed by headache, muscle weakness or general fatigue, and confusion or lack of concentration. These symptoms are in keeping with the currently available literature, although we do feel that as our sample size increases, we'll be better able to describe our findings in relation to international studies. There are some international studies that have found higher prevalence of brain fog or confusion reported by these patients, although fatigue and shortness of breath were reported more commonly among all symptoms. This table comes from the previous figure of most common symptoms amongst patients at 1 month follow-up, with comparison between male and female groups. Within shortness of breath group, the results were similar between both males and females at 34%. Females reported headache more often than males at 22.5% versus 16.4%. Muscle weakness was more common in males than in females at 20% versus 18%. Confusion was reported more in females than in males at 21.4% versus 16.2%. And interestingly, a persistent dry cough was a common feature amongst both populations at an average of 16%. Other common complaints included chest pains, problems sleeping at night, dizziness, and blurred vision. Of all the patients enrolled in our study thus far, a very small number of 54 patients have reported severe complications. 7 patients reported history of heart attack, 2 patients reported history of deep vein thrombosis, 4 patients reported history of stroke, 14 patients reported history of pulmonary embolism, and 26 patients reported history of kidney problems. There was a slight male predominance for kidney problems, otherwise no immediately apparent difference between sexes in the category was noted. When we look at the difficulties associated with activities of daily living by sex, we found that in terms of mobility, there was a majority of patients who did not find difficulty in activities of daily living. However, 27% of both males and females experienced some difficulty with regards to mobility. Next, with regard to pain and discomfort, there was a higher percentage of females who reported pain and discomfort than males at 25% versus 17%. In terms of the ability to perform self-care, males felt that they were better able to look after themselves relative to their female counterparts, albeit a small difference. And finally, we looked at anxiety and depressions, and females reported higher rates of anxiety and depression than males at 34% versus 22%. If we look at some of the activities of daily living changed following acute illness, we can easily see that for the vast majority of patients, there is no change in the ability to see, hear, walk, remember, or look after themselves. But when we look at the smaller values at the bottom of the table, nearly 20% of patients reported that they felt they were less able to walk now than before they became ill. 17% of patients reported some difficulty in remembering in both long-term and short-term memory. Nearly 10% of patients having difficulty seeing after their illness, 5% struggled to look after themselves by washing, changing, or feeding, and 3% of patients now reported difficulty in hearing. Patients were then asked how they perceived their health on a scale of 0 to 100. We have simplified the scale to a scale of 0 to 10, where 0 is the worst health that they could imagine, compared to 10 being the best health they could ever experience. Most people reported a health score greater than 8, which ultimately is a good thing, while 16% of females and 50% of males reported a health score less than or equal to a value of 6, which lies towards the bottom end of the scale, which is somewhat concerning. In terms of fatigue intensity, patients again were asked to rate the level of fatigue on a scale of 0 to 10, where 0 was no fatigue experience compared to a level of 10 being the worst fatigue they've ever experienced. And a large proportion of patients reported a level of 0 and experienced no fatigue, whilst 38% of females and 37% of males reported a level of fatigue greater than or equal to 5. With regards to to how patients felt in terms of their breathlessness and fatigue after COVID-19 infection, 33% felt that they were worse off than they had been previously. And when patients were asked to compare their level of shortness of breath from before they became ill with COVID-19 to the level of breathlessness now, there was a noticeable difference. Patients who had reported that they had not been troubled by breathlessness except on strenuous exercise dropped from 91% to 59%. Patients reported they became short of breath whilst hurrying or walking up a slight hill increased from 2% to 17%. Patients who reported that to walk slower or had to catch their breath because of breathlessness increased from less than 1% to 10%. And patients who stopped for a breath after walking 100 meters or a few minutes on level ground increased from less than 1% to 7%. Finally, patients who reported they were too breathless to leave the house or during activities of daily living increased from less than 1% to more than 2%. Finally, looking at lifestyle changes, the majority of patients enrolled in the study reported that they were working full-time from before COVID-19. Looking at patients' occupations after COVID-19, nearly 10% reported they were doing something different to what they had been doing beforehand. And from the 10% of patients who reported they had a change in their occupation following their acute COVID-19 illness, 70% of these patients reported the reason for their change in occupation was related to persistent COVID symptoms or long COVID. Finally, when we asked patients about their social habits such as smoking, drinking alcohol, eating healthy food, and performing physical activity, we found that about 3% of smokers were doing it less. Nearly 21% of patients were consuming less alcohol, although we may need to consider the effects of lockdown on this figure. And amazingly, 49.7% of patients reported they were eating healthier food. Unfortunately, only 21% were exercising more, whilst 30% were exercising less. So what next for us and for PACE6? We need to develop robust guidelines outlining the identification of PACE6 patients, management strategies, and providing training to healthcare workers at all levels to better equip the healthcare system to address these problems. We'd like to form important collaborations with the National Department of Health, mainstream media, and other advocacy groups with the aim of improving the health messaging of PACE6. We are in the process of developing a platform dedicated to informing the general public on what PACE6 is through the Your COVID Recovery website, which I will discuss shortly. This platform will assist to disseminate information to members of the general public and will assist with enrollment in studies similar to our own, as well as provide the ability to launch virtual consultations within the healthcare system. With regards to further project expansion, we'd very much like to expand our project to include non-hospitalized patients, which is currently not available. With regards to occupational health recommendations, formulation and dissemination of guidelines remains important. Healthcare workers cannot manage a condition they do not know about or understand, and training will be important in that instance. In addition, we need to remain vigilant that not all patients may develop PACE6, and their presenting symptoms may be as a result of other communicable and non-communicable diseases, including TB, PCP, and other HIV-related opportunistic infections, as well as autoimmune conditions, neoplastic disease, and chronic fatigue and pain syndromes where analgesia may prove important. Patients need to be informed and empowered as to what to expect, be given guidelines in terms of self-management strategies and when they should seek out. The more patients know, the better their outcomes can be, and hopefully this will provide an additional relief to the healthcare system. We have already had some requests from healthcare workers looking to refer patients to specialist PACE6 clinics, which could provide clinical support to patients and has the potential to improve data collection on our side. In terms of provision of support services, the literature has shown there's been significant psychological impacts that PACE6 has on patients, and that addressing these issues will support patients during their physical recovery. Some patients have experienced employment changes due to conditions as found in research globally as well as our own, and the provision of social support will remain crucial from an economic standpoint. Although not discussed in detail, the provision of occupational and physiotherapy in some cases to patients who experience persistent symptoms may be of benefit. As mentioned on the previous slide, we have been working on a collaborative project with the Your COVID Recovery team in the UK. Their platform aims to address questions from patients who became ill with acute COVID-19, as well as those who have gone on to develop PACE6. And these topics covered include those on the list of the slide, including what COVID is, guidance on supporting patients' well-being during recovery, and how to manage their life after COVID-19 illness. We have already approached the NIOH, and we plan to integrate a national occupational health tab within our website when we launch it, where healthcare workers can provide referrals to our patients for further information. If anyone is interested, please see the attached link for a video testimonial from 2 PASIX patients in the United States. And finally, I'd like to thank our entire research team, from research assistants and surveillance officers responsible for our data collection, as well as the entire NICD and DATCOV team for all of the support they have provided to us and the project. In addition, thanks to our partners at SARIC, responsible for our project support, and to our sponsors, the Bill and Melinda Gates Foundation. That's it from me. Happy to take any questions, and thank you very much for listening.
Thank you very much for that presentation, Dr. Murray Dryden, a member of the DATCOV hospital surveillance team at the NICD, together with his colleague, Dr. Washila Jasad, who's also the coordinator of the DATCOV hospital surveillance team at the NICD. And that was the topic on long COVID, global and South African data, looking at quite a number of key subtopics. What is it? Clinical presentations, challenges with diagnosis, literature and methodology, global stats, and SA data. And we can clearly see this is an area that we need to monitor, and the information and developments here is going to be ongoing, and we would probably require some update, hopefully not in the too distant future, for us to be fully understanding what this means for us within the workplace and what we've got to do in our workplaces to deal with it. Thank you very much, Dr. Dryden and Dr. Jasad. Our next topic is the impact on the workplace and considerations for fit for work certification by Dr. Neil van Tonder. And I'm going to ask the attendees who are typing general comments in the question answer box, please refrain from typing your general comments, your thank yous, and so on in the question and answer box. Do that in the chat box, please. The question answer box is only for the questions directed at our presenters and the content of their presentations. Thank you very much for that. And then there is still one person who's got a raised hand. Please just lower your raised hand. We cannot respond to raised hands when we have almost more than 700 people on this particular webinar. So whilst Dr. van Tonder, back to our topic, is just preparing the slides that he will be sharing, Dr. Neil van Tonder, I just want to secure quickly my bio sketch of Dr. van Tonder to share with you. So Dr. Neil van Tonder is an occupational medical practitioner, apologies, with more than 25 years experience, and is the co-founder and chief medical officer of eHealth Africa, a health software company with a footprint in Central and Southern Africa. He's dedicated to the digital health transformation in Africa, and he has invaluable experience in establishing occupational services in developing countries. Is also instrumental in establishing occupational health as a recognized medical subspecialty in the Democratic Republic of Congo, the DRC, providing them with a national digital health solution. He's based in Cape Town, from where they manage projects locally and internationally. With those few words, Dr. van Tonder, I'm handing over to you. Thank you very much for joining us today and making the time to share your experience and knowledge with the NIH's webinar attendees. I hand over to you, sir.
Yes, thank you very much, and thank you for the introduction, and good morning to all the participants, and also to the NIOH for hosting this event. I'm sure the presentations will be shared, later on. So one or two of the slides I'll just pass over very quickly, just due to time constraints. All right. So without further ado, let's just go to this. Okay. So we've touched on the definitions and so on. I'm not going to dwell over this, anymore. Dr. Dryden has actually described it already in his presentation. Then, as far as the how do we actually address it? So I think, as with a lot of disciplines in medicine, we start with the history. Okay, so the history of a suspected of a acute there must be a history of a suspected or confirmed case. Of course, you must have a look at the nature and severity of previous and current symptoms, the timing and duration of symptoms since the start of acute COVID, and of course, the history of other health conditions. It is important, apart from the general questionnaires that we used to with occupational health, prior to assessing an employee, we must incorporate these specific questions and be prepared to go into the detail. Otherwise, you will certainly miss it. If you go to the NICE guidelines, the symptoms are highly variable, as we've seen with Dr. Dryden's presentation, and wide-ranging. And the most commonly reported, and I've got no doubt that other symptoms will also be reported, maybe to a lesser extent later on. But these include, of course, respiratory symptoms. And from an occupational health point of view, we need to ask ourselves, given that type of symptoms, how would they impact the specific working environment? You could imagine wearing a respirator, ready with resistance, being exposed to chemical irritants, doing, work that performs strength and endurance, for instance, in construction, underground, and mining and engineering, that will be quite difficult for that individual, and the individual might be wanting to take off the respirator. Of course, the same will apply with coughing, and also exposure to chemical irritants, In terms of cardiovascular symptoms, tight chest, again, we're looking at the same type of things, respirator, chemical irritants, physical work, work that require endurance, underground work, engineering, and people working in foundries, and exposed to relatively high levels of dust and things. Chest pains and palpitations also being experienced by these patients. It is important there that we need to know whether this person will be working in a remote area, and if he presents with chest symptoms and palpitation, there should be, a medical facility at least accessible, for ECG and a medical evaluation, General symptoms, fatigue. Again, a lot of we work in a developing or country where it's still a lot of manual labor, and these are quite important to take cognizance of. Fever, of course, pain. Dr. Dryden has also touched on that. Physical work, again, underground mining, engineering, heat work. These are all the type of assessments that we used to in occupational health, given the regulations that we are dealing with and trying to comply with. Cognitive impairment, the so-called brain fog, loss of concentration, memory loss, clarity of thought, where clarity of thought is required. You may want to consider doing a mini mental, and help, and it might aid you in your decision making when it comes to the medical adjudication and certification of an employee. All right. Headache, of course, very difficult to do that in a heat environment, underground or in foundries. And then, of course, sleeping disturbances also being cited, and then we think of the shift workers, your long distance truck drivers, and remember, a large portion of our employees actually need to travel vast distances, having to get up very early in the morning, to get into work. Which further impacts on these sleep disturbances. Later on, I'll touch on a way to assess that, or on a suggested one of the technology aids to help us to assess sleeping disturbances, which I personally found quite helpful. Neurological symptoms, peripheral neuropathy, people working with vibrating tools, power tools, whole body vibration, for instance, forklift drivers, and of course, those working in cold storage facilities, these can all worsen the symptoms. All right. When, of course, dizziness, there we know about people working at heights and operating mobile machines and vehicle, and delirium, which seems to be more problem in the older population, and there we could maybe also use a mini mental. All right. Gastrointestinal symptoms, a couple of them. What is important is those with diarrhea. If you certify individual fit for work, what is accessibility, to toilet facilities, anorexia, reduced appetite, especially or more so it seems to be through preliminary research in the older population, and very important if you have a diabetic, not eating with reduced appetite, you might have somebody, having bouts of hypoglycemia. So it's important to ask these pertinent questions, all right? Musculoskeletal systems, worse in cold environments, and of course those with pre-existing osteoarthritis, rheumatoid arthritis. Think about those climbing ladders, needing to walk in awkward positions or angles. Joint pain, muscle pains. Again, we're looking at physical work, underground work, engineering, heat work. And then, of course, we've touched on the psychological and psychiatric symptoms, shift workers, those that are isolated. We think about the security workers, not having a lot of being posted in very quiet areas, very monotonous type of work, And it's also perceived, and I think Dr. Kleynhans touched on that, it's perceived that we suspect that depression and anxiety might become a bigger problem later on, if not identified and addressed earlier, which could impact the working environment even more so. All right. So your ear, nose, and throat problems, again, tinnitus, somebody needing to hear subtle sounds. It might be somebody to do with music, or a music instrument tuner, or an engineer that needs to be aware of the fact that there's something wrong with a specific bearing, for instance. Then, of course, there might be a subjective feeling of earache, needing to wear PPE, and the individual might want to remove the PPE. Then again, dizziness, working at heights, conditions where balance is required, working maybe on scaffold. And then loss of taste and smell that could persist. Analytical chemists there, quality control in the food industry, or where smell is required from a safety perspective, maybe a liquid petroleum gas leak, And then, of course, dermatological symptoms are also, skin rashes are also reported. Maybe the individual is already working in conditions or environment where they, from time to time, they do experience skin rashes. So when do we refer? Now, urgent referral is required where there's severe hypoxemia or oxygen desaturation on exercise. And there's a small little practical test which I'll share with you in the next slide or two. And then, of course, is there any severe lung disease, or respiratory symptoms, chest pain, of course, needing to require ECG and proper cardiac assessment. And then maybe not so important for us, is in the adult population, but certain children, so-called multi-system inflammatory syndrome. So these are the next two or three slides is from our distinguished colleague, Dr. Greg Q, and his definitions of fit for work certification. So you need to look at capability, and capability will have two components, and ability. We'll come to ability just now. So capability is ask the question whether the individual is able to perform the tasks required to the correct standard. Okay, and then we look at quality. May require good vision, or fine motor control in certain conditions. And then, of course, the efficiency may require strength and endurance, or flexibility. So very important, without undue risk to him or herself and others. So if we look at the type of symptoms and we've identified those symptoms, we need to ask ourselves whether this person is actually capable of performing the work. Ability is the ability to function in working conditions associated with a job, okay, given without undue risk to his or her health, and conditions that increases the vulnerability to working in such conditions, such as poorly controlled asthma in the presence of respiratory irritants and cardiac failure in hot working environments. All right. Fit with restrictions, just touch on that briefly. It is, you can either, those restrictions can either be task restrictions, exclusion from certain tasks, okay? And then also workplace restrictions, restrict the worker from working in certain working conditions or a certain area within a factory or facility, all right? And very importantly is the duration of such restrictions on fitness should be stated. Okay, and there's nothing wrong to assess again and make somebody fit for 1 week or fit with restrictions 1 month. Review the situation, etc. All right. Unfit, of course, it means that they do not meet the minimum inherent requirements of that particular job, even if suitable restrictions are not applied. So a little tool that we use is a medical assessment. You can either be fit or unfit. If you're unfit, you can be fit with restrictions, temporary unfit, permanently unfit. And the reason for that, call it unfitness, could be as a result of not meeting the required medical standard for the specific job, pre-existing uncontrolled condition, newly diagnosed chronic medical condition, suspected unconfirmed occupational disease, or confirmed occupational disease. So in our case with COVID, it will be most likely newly diagnosed chronic medical condition being responsible for that particular status. All right. When it comes to the occupational assessment, it's a typical that we follow the type of job, the medical history, screening, examination, side room test, special investigation, and additional tests to consider. And we'll go through each one of them. So the type of job, commonly referred to as the man job spec, should be available. I know from a practical point of view, the employers hardly make these documents available when you do the assessment. Or more correctly, we refer to the occupational risk exposure profile, or the OREP. And that takes into account the physical requirements, work environment, the hazard exposure, safety equipment, exclusive and special considerations, and suggested limits and standards. The medical history should include, and one should amend it if you have a standard document for that, suspected or confirmed acute COVID-19, the nature and severity of previous and current symptoms, the timing and duration of symptoms and the start of acute COVID-19, and certainly other health conditions. So we normally have the standard questionnaires, the Epworth sleepiness scale, the stop-bang questionnaire, which assess obstructive sleep apnea, and respiratory questionnaire, and so on. But there is a need for a validated questionnaire for long-term COVID to help us. All right. So your physical examination and your observations part of that, and then of course the other tests that you're familiar with. Again, the antibody test might help you with a diagnosis there. The additional tests could be considered, and research will tell us whether it's appropriate or not. I'm just putting it here because it was cited in one of the documents that I researched. A very simple so-called exercise tolerant test can be done, for example, for 1 minute sit and stand test, and document the exercise, record the level of breathlessness, the heart rate, oxygen saturation, and so on. It might just aid a little bit in your decision. Chest x-rays, if appropriate, but you might miss, of course, some of the other symptoms. As was previously mentioned, it's more a question of, at this stage, of excluding other medical conditions given the type of symptoms. Psychiatric assessment, refer rather earlier. All right, ECG for chest pain and palpitation. Again, SARS-CoV-2 test, PCR antigen test. I'm not saying do it in all of them, but it might be, particular cases, something that you need to consider. And of course, the sleep study. So I make use of sleep image. It's nearly like a very fancy Fitbit type of device. It does a beautiful cardiopulmonary coupling, give you a magnificent report at a fraction of the cost of a polysomnograph that the individual can do in the comfort of his or her home, giving invaluable information and very easy to use. Symptoms impacting on the function that may impede, return to work is, of course, more so the fatigue, shortness of breath, chest pain, and neurocognitive impairment. But these things might also be responsible impeding the travel back to work or to and from work. So general occupational health principles, just quickly go through that. Work is generally very good. It boosts self-esteem, enable financial independence. We're all aware of that. And unemployment usually perceived as poor physical and mental health, increased risk of self-harm. And there's a direct relationship between the length of sick leave and becoming unemployed. So if you're more than 6 months on sick leave, the probability of being unemployed or unable to return to work is 50%. Return to work is an effective part of the rehabilitation and illness in the process. So we established the current level of health, assess the need for investigations, as we already mentioned, to exclude underlying organ damage, identify and manage comorbid depression and anxiety, and as I've mentioned, become more of a concern the longer someone is away from work, and inquire about sleep patterns and give sleep hygiene advice if required. So at work, take into account the type of work, the number of hours per week, what is the normal workday involved, what aspect of the work is affected by the functional impairment. Establish if the work is safety critical, for example, working with machinery or driving. If we look at work and health, the main factors impeding the return to work, ask them about that. The solutions, because sometimes they will provide the solution. Solutions to the return to work obstacles, discuss adaptation of work with management, look at flexible hours, working from home, special equipment, encourage them to liaise with the employer to see if the adjustment could be facilitated. So some would, the work certificate that they provide might include something like a phased return to work recommendation, altered hours, amended duties, and workplace adaptation. So it's just not just fit, unfit, fit with restrictions, etc. You might want to add those. So the key recommendations, the second last slide, the key recommendations for research is we need to establish, the researchers like Dr. Kleynhans and his team, and the risk factors for COVID-19 syndrome, and we've heard some of them from the preliminary data. What factors influence, including identifiable clusters of symptoms, influence this? The risk of developing COVID-19 syndrome, the trajectory of the syndrome, interventions for COVID-19 syndrome, the prevalence of COVID-19 syndrome. I know in the UK, they say about 1 million people suffer with that, and mainly the biggest portion is the age group 50 to 59. But I say that's in the UK. Prognostic markers of developing COVID-19 syndrome. Now, what is the clinical effectiveness of D-dimer and other blood tests and prognostic markers? And to develop and validate the new screening tools, including physical, psychological, and psychiatric aspects of COVID-19. It was a little bit rushed, okay, but I'm sure you all will understand, and I will share this with the team at the NIOH, get it right. All right. Thank you very much for your attention.
Thank you very much to you, Dr. Neil van Tonder, eHealth Occupational Medicine Consultant, dealing with the topic, the impact on the workplace and considerations for the Fit to Work certifications. Thank you, Dr. van Tonder, for your contributions and your time that you've dedicated for this webinar. Our next topic is by Dr. William Kleynhans, dealing with the management of COVID-19 in the workplace, designing a workplace program. Dr. William Kleynhans is an emergency physician, and whilst the slides are being shared, and I will just want to quickly get Dr. Kleynhans's bio. So Dr. Kleynhans is a medical doctor with health insurance and digital health expert, as well as digital healthcare projects in Africa, Southeast Asia, Europe, and the United States of America. He's the lead author of the South African telemedicine guidelines for the DHCA, and Dr. Kleynhans can just tell us what the DHCA is. Also designed and implementation of multiple disease management, risk management, and clinical services projects. Dr. Kleynhans has 12 years of insurance medicine experience and 15 years of emergency medicine experience. He's previously was the medical advisor and the chief medical officer, Allegra, the international medical advisor and MedScheme. And with that very short introduction to Dr. William Kleynhans, I hand over to you, Dr. Kleynhans. Your slides are definitely maximized and visible. I just want to check if your microphone is fine.
Good morning, Ashraf. Good morning to all the attendees and the panelists. Can you hear me clearly?
Perfectly. Thank you very much. Please proceed.
So firstly, thank you very much to the NIOH for this opportunity. And also thank you to the previous speakers, Dr. Dryden and Dr. van Tonder and their teams. I think that was excellent and informative. My talk is going to be a little bit more practically focused, and it's based on the last 3 months of work that we've did with the support of Dr. Elton Dawkin at Anglo American, as well as excellent input and the groundwork that was done by Dr. Heinrich Vollmink. In the 20 minutes time, I'm just going to focus on some principles and then show you some practical examples. Just a quick bit. So Stone3 is a health technology company and consulting company. And we do work mostly in the area of heavy industries, helping companies to use modern technology like artificial intelligence, etc., to optimize their processes. So I think it's first important, as Dr. Dryden and Dr. van Tonder pointed out, it's still very early stage. And I think the quote by Peter Otis, is a well-known vaccine expert, really says a novel virus can make a fool of even experts. So we're very early on in the stage, and from a planning perspective, there's many things we do not know. If you look at the numbers on the left, 17, 26, etc., those are the ages of current patients in ICU being ventilated in Brazil. So even though it's been a severe disease for the elderly, we do know that the new variants pose challenges for younger populations. And so one must think that the whole workforce is at risk. And that's for COVID. As far as long COVID is concerned, I think it's easy to say that it's an unquantified risk at the moment. So some numbers are 10%, some are 25%. We've even seen numbers as high as 80% in some symptomatic studies. The other challenge is that managing long COVID or PASC requires multiple stakeholders. Because there's multiple conditions, there's also HR implications, mental health implications, respiratory specialists, respiratory physicians involved. The advantage of where South Africa is at the moment is that we're probably in between two waves, and therefore we can focus on long COVID now. But the moment that the next wave hits, there will be a lack of capacity to look after those that are essentially considered well by many workplaces because they might have returned to work even though they are symptomatic still. In some sites where they're seeing 80 plus cases a day, focusing on this problem at that stage is a challenge. And therefore it requires careful planning. From a treatment point of view, when one looks at designing a program for long COVID, I think the previous speakers highlighted the issues and the conditions, and Dr. van Tonder gave an excellent talk on actually the practical areas and the tools that one can use from a clinical point of view. But the cluster of fatigue, ME, and chronic fatigue syndrome means that it's quite difficult at this stage to really nail down what is considered PASC and what isn't, as well as with many of the other conditions. The NICE guidelines also make note of post-ICU syndrome as an exclusion factor for considering someone. So the definitions aren't 100% clear. Many of these patients, even though they have limited initial symptoms, end up with pulmonary complications, as mentioned previously, and I've seen it in clinical practice, people months later with affected lung functions, and then a complex neurology. So we've got young patients with altered mental status, we've got elderly patients with strokes. As the previous speakers highlighted, there are also a complicated cluster of from depression, anxiety through to new onset psychosis that one has to do. So it's really a complicated condition to manage. So how do you start by looking at these complicated conditions? And I'm going to talk to you about a tool that's used commonly internationally in healthcare management called care pathways, which many of you might already be familiar with. So if you look traditionally when you design a program, the one way to do it is to do it from the top down, sometimes called system-centered design. And the approach in system-centered design is to say, this is our system, this is how we're looking at it, and we're going to try and implement systemic controls and processes. It's also a more safety-based approach as opposed to an individualized, and it almost it's got a very realistic view of humans, saying that humans are prone to error, so you've got to design it in the system. This approach was really kicked off in healthcare in early 1999, 2000, when there was a rapid rise in medical errors, especially in hospitals. So it's become a very popular way of looking at problems. And that's a top-down approach. The more modern approach that's been in use extensively, especially in the software development, technology development world, is called user-centered design. So it's a bottom-up design. And the idea is to look at the customer or the employee or the end user and look at their journey through the process. And if anybody's been involved with any software or technology process, this is extremely popular in that area. The challenge in healthcare is that you need to combine both approaches. You need to combine both a systemic view, because there are multiple elements and multiple stakeholders involved, and you need to look at a user-centered design. In other words, you need to say, how will the customer or the employee experience this? It was initially popularized in the 1980s, and it's become almost a de facto way of healthcare management teams designing, especially if there's a clear problem like we have now with post-COVID or PASC. We need multiple disciplinary care teams where efficiency and patient satisfaction is important. So one of the leading groups globally is the National Institute of Clinical Excellence, and you can actually go online and find many of their care pathways nicely mapped out with guidance. The big advantage of this approach is that it puts everybody onto the same page, especially if you're working in an organization as an occupational health physician, where you're working with management, where you're working with HR, maybe you're working with external providers. It gives everybody a clear view of how one sees the journey progressing. It also gives a template and a blueprint to the technology teams the moment that you want to integrate any technologies to try and deliver many of these. So it helps those areas that you sometimes see where you sit in a team and you say, but the system doesn't work like that. It just helps everybody focus on the problem and align with the expected journey. So what are the basic steps in putting a care pathway together? So step one is putting the committee or care pathway team together. And this is very important when you're planning a program for your organization. Many of the challenges of implementing any new solution or doing any change management really comes from not having all the stakeholders on the same page. It will help you also get approvals and budgets in a timely fashion. Sometimes the challenge of rolling something out is actually more internal than the actual condition. So that team then sets the target pathways, and this way In this case, it's long COVID, what the expected goals and outcomes is. In this scenario, for instance, with long COVID, it might just actually be that your initial goals is just identifying those with severe symptoms. And then the next step is to define inclusion and exclusion criteria in the pathway. So in many ways, it's like a little mini clinical trial or a small project that you're going to be moving employees through. The next step is to look at resourcing, define your care teams that you expect to be involved. And remember, what makes long COVID or PASC so complicated is that you're going to require external providers for some of these areas, like mental health, like respiratory rehabilitation, or cardiac care. Then, once you've defined your care teams, make sure that you don't miss out on the important part, which is the admin teams and the logistic staffing. What makes a care pathway so unique is that it doesn't only consider the clinical steps, but it also considers the practical steps of moving someone from point A to point B. And then the final thing is your plan for case management or care coordination. Care coordination is very tightly integrated into care pathways. And the importance of that is someone then takes ownership and almost holds that employee's hand from the beginning of the journey to the end of the journey to make sure that they do not get lost to follow up or diverted, or that they get tracked into the right streams. Once you've done that, you can start mapping. Dr. Dryden's team has done most of the groundwork for you there, so you can almost copy and paste that presentation, but you need to start with gathering existing research and evidence so that you can make the right clinical decisions at the right points. Once you've defined your entry and exit points, in other words, where does your employee start in this process and where do they exit? You can start drawing a high-level process, usually fairly straightforward with a team around a whiteboard. Don't try and do all the processes in one drawing. Try and map out where there's sub-processes that you need to do and identify the decision points and criteria. So a good example would be, for instance, who are those people that still have acute symptoms that need to be referred out? Then the next step is develop your SOPs to align with the care pathway. So a care pathway is for the team and the committee and to get everybody on board. But the care teams and the case managers need clear SOPs and guidelines to help them do the work and track the employee through this process, basically giving them a recipe of what to do when. If you've got the capacity available, or you've got the internal teams, then the next step is to map this to your digital systems that you have on site. So that might be Dr. van Tonder's electronic healthcare record system. There might be a ERP system involved at your company. There might be a medical aid process that you need to map into. And the idea behind that is to really start automating and making sure that the data flows in the right way, in the same way that you envision the patient will flow. So what does this all mean in a practical example? So I'm going to share with you a very high level of the roadmap that we are working on at the moment. There's obviously lots of details and complicated stuff in the background, but it should just give you an idea. And we are learning every day. We've almost on a weekly basis getting new information and getting new insight, especially from the people on the ground who are responsible for caring for these patients or employees. So at a high level, our process that we mapped out as a practical example has an entry point. As you can see from the previous speakers, there's two definitions. One is the 4-week definition, and then one is the 12-week definition. And we expect that we will pick up some patients later along the line that do not fit any other condition and might have been missed first week around. Those employees are then triaged. And remember, triage isn't only someone speaking to a patient doing their blood pressure. You can triage your employees according to the type of work they do, according to their age, according to their previous medical conditions. In certain areas after that triage, with no symptoms, they either return to work if they haven't returned to work already after 4 weeks in a fairly straightforward, simple symptom. If they do have acute symptoms at that stage, you need to just consider an acute management process to refer them out. From that triage process, based on the previous data and the telephonic assessments or virtual assessments or app assessments, some of those employees then end up with a clinic assessment. So theoretically, someone can move from triage straight to the occupational health clinic. But one of our goals that we set out was to reduce the workload at site level, so on the occupational health clinic, and try and screen out those that might have less symptoms or do not require extensive further involvement. And the clinic then refers on either to rehab. Certain employees might require the fitness to work assessment as outlined so clearly by Dr. van Tonder. Our process also included a long COVID clinic. And when you design a process like this, we're initially just screening and managing the large initial group. It's important then to, once you've identified those with significant symptoms, is to keep them together, track them, and get your expert insights, and maybe just set up a clinic specifically for those. Now, the great thing is at the moment, there are excellent tools available at all of these steps. So you can use your EHR, ERP systems to help you with triage. There are fantastic patient apps that they can self-assess and track and monitor. On a practical level, call centers are very useful to do mass screening. Some countries like Israel, they're using chatbots to do some of these screenings. And then wearables has got a rapidly emerging role to also monitor symptoms and track patients for both the acute management and the triage. As I said before, it's very important that not only is the clinical pieces looked at, but also the practical kind of logistical flow. So employee portals and workplace engagement tools have an important role in helping the employee return to work. And as we said earlier, I'm really excited to hear that we're matching the UK with a COVID recovery tool as a national resource. That will be incredibly valuable for practitioners to refer people to with clear guidance. At clinic level, telemedicine is a great tool. It's been a great tool throughout the COVID epidemic, and remote monitoring as well. And that allows you to see people at their home or to empower nurses at remote sites with a doctor consult for an opinion. Then there are many digital programs and online rehabilitation programs available at the moment. And the same tools, so telemedicine, wearable, and some of the AI diagnostic tools are also available to empower the occupational health clinic. So in the same way that you can bring a doctor to a nurse remotely via telemedicine, you can also bring experts. And in my view, that's a great way of empowering your long COVID clinic if your respiratory physician or your cardiologist is far away. As I mentioned, there's some AI diagnostic tools on screening actually, so rapid screening of chest x-rays to identify any lung fibrosis or any other conditions. So, and this field is rapidly developing. There are many companies looking at all these different time points and trying to develop new tools. So in conclusion, when you design a workplace program, I think the most important thing is there are more cases out there than we currently know about. In the future, we're going to see more of the variants, especially if you look at the P1 variant from Brazil, that will be affecting younger patients. So we're going to see younger people with post-COVID syndrome. It's absolutely important that management is done in a care coordinated fashion for long COVID, specifically because it involves so many specialty areas and so many areas of the employee's life. For us, the big challenge is still understanding this chronic fatigue syndrome overlap, and when does that diagnosis happen, and the effect that that might have on continuing employment. Use care pathways to map your workplace program That way you can align the employee in the system and really create an excellent experience. And then very important, work in teams. If you try and do this by yourself, you're going to struggle with sign-off and buy-in. And finally, like I said in the previous slide, there are already excellent tools and providers available to help with different parts of the process. So to finish off, thank you very much and for the opportunity, and I hope you've learned a little bit something. For myself, I mean, the two previous presenters was excellent, and we're going to be working some of that knowledge back into our program already.
Thank you very much. That's Dr. William Kleynhans dealing with the very practical topic of management of COVID-19 in the workplace, designing a workplace program. And as he has indicated, what he has offered us today, all of this integrates very well with the presentations earlier on by Dr. Murray Dryden on behalf of himself and Dr. Washila Jassat. And he has acknowledged some of the other colleagues that they work with that has contributed to the collective input to their presentation, and then also the topic of impact and workplace and considerations of fit to work certification, Dr. Neil van Tonder from the eHealth Occupational Medicine Consultant. Thank you for that. We have some minutes in order for us to deal with some of the questions. I'm going to ask those presenters who've already cast an eye over the question and answer box and looked at the answered questions to see the trends there, as well as a few of the open questions that is there. Thank you, Cheryl. Cheryl just made a general comment in the question and answer box again there. Please make your general comments in the chat box. Okay, so I don't know if I could quickly ask Dr. Murray Dryden and Dr. Washila Jassat if they want to perhaps make any comments on the questions that they've seen there in the question and answer box, as well as any additional comments or observations they want to share given the other presentations. Could I invite the two of you, Dr. Dryden, Dr. Jassat, if you want to please add any additional comments. That invitation is also extended to, let me just check, to Dr. van Tonder and Kleynhans.
Thanks, Ashraf. I think if I can just say thank you for the engagement from the participants through the Q&A. One thing I'll just comment is that there's so much not known yet about PESC, and so a lot of the questions that were asked, I think we just need further studies, and we need a longer time for follow-up of our own participants in our study to be able to answer some of these questions. So I think what I can say for sure right now is there's still a lot that we don't know. I think that there's a lot of implications of the study, even without having all the information. We need to think of the implications of these findings for health services and for the workplace. So we shouldn't let the lack of evidence paralyze us in terms of moving forward. We need to already start thinking about what services are needed and what kind of case definitions and clinical guidelines and clinical treatment is required. Thank you.
Okay, so thank you for that. Just a quick question. Your own study, approximately when, I might not have followed the presentation in detail, would the results of your study hopefully be able to be shared with the general public and those responsible for prevention in the workplace? Dr. Jassat?
Thanks. We're doing follow-up of these patients at 1 month, 3 months, 6 months, and 12 months. We've just completed 1 month follow-ups, and we're going to release those findings. So I think we'll keep releasing data as we reach those time points, and then the final study results will be available around next May or June.
So thank you very much for that. And then I'm not sure if Dr. Dryden wants to add something, and then Dr. Kleynhans, as well as Dr. van Tonder. Any comments from your side on the general trend of the questions raised in the question answer box, or additional comments you want to make? Dr. Dryden, I see your microphone is open. Go ahead.
Hi, everyone. So I think one of the questions that did come up was whether asymptomatic or non-hospitalized patients are also at risk for PASC. There is less literature with regards to asymptomatic patients and non-hospitalized patients, but there is literature regarding them. One of the studies that I did discuss actually compared patients with mild disease or asymptomatic patients who tested positive for COVID compared to colleagues who had not, and found that there was a higher risk of developing PASC-related symptoms in that population compared to the other. So it is a risk factor. As I said earlier, with regards to disease severity, it hasn't been shown to be a significant risk factor in terms of whether you develop it or not. They still believe that patients who develop severe disease, as well as those patients who are either mild disease or asymptomatic completely, are still at risk of developing PASC. But with regards to actual facts and figures, we don't have any of that research as so far. The other question that I did also see with regards to vaccination, we don't have a lot of data on that. As I'm sure everyone can appreciate, with regards to the release of vaccines and some of the bumps along the way with different vaccines being suspended, there isn't sufficient data to make comment on whether it's protective or not with regards to development of PASC. I think the studies that the vaccine manufacturers will do themselves will also contribute to that knowledge. And we will only have full in detail knowledge whether it is preventative later on. To answer that question, yes. And then I think there was a question as well with regards to vaccination. It's also important for everyone to remind patients that even though you may be vaccinated and you may have some level of immunity, you are still at risk of still being infected with COVID and spreading it, even though you may not go on to develop moderate or severe disease, if not even mild disease. So even with vaccination or previous levels of infections, patients are still at risk of developing infections from COVID. And that's predominantly due to waning immunity as well as the development of new variants. And I think that's a very important message to get across to patients and other healthcare workers alike. Thank you.
Thanks, Dr. Dryden. And over to the other two colleagues, either Dr. van Tonder or Dr. Kleynhans. Dr. van Tonder, please proceed.
Hi, thank you. Yes, I think we're, if I just to briefly talk about digital health, it's not going to happen, it's already happening. And to me, it's well, to our company, it's all about participative care. You know, the direction of medicine is moving towards empowerment. You know, everything is cell phone based. You know, in Nigeria, they sell about 70 new cell phones, smartphones, you know, every minute of the day. And I think we should actually, the onus is or put the power, empower the employees, you know, to recognize these symptoms, you know, Dr. Kleynhans alluded to that, you know, there are a variety of tools available and being developed actually to facilitate that whole process. And this will not be the first pandemic, you know, and we should prepare for future pandemics as well, and start using technologies more, and of course the research based on the research that's being supplied, you know, to address these problems in the future. All right, thank you very much.
Thank you, Dr. van Tonder. Any particular observations and comments from you, Dr. Kleynhans? Please proceed.
Yeah, I just want to agree wholeheartedly with Dr. van Tonder. There's the nice advantage of this. Imagine if we had to do this kind of response during the Spanish flu epidemic, is that the game changer has been digital technologies. It's enabled us to scale our response, both from an information and from a clinical point of view, very, very rapidly. And we should use this as a stepping stone to empower the patient and the employee, as he alluded. Just a quick comment from my side. One of the things that we've noticed is there is an incredible amount of information about people's responses in the post-COVID in fitness to work assessments. And I think there's an opportunity for someone to really look at people who've had COVID and what happens at their fitness to work assessment. So I hope that that gets looked in. That will enable us also to and to plan better going forward. And then maybe just the final topic is that I do hope that we take the opportunity with the massive data sets we had to also start doing genomic analysis. Our population that we are treating in South Africa and Africa is really unique. And with these big data sets and identified patients, we have the opportunity to start doing precision analysis. And with the capacity that we have got at the MRC in Cape Town, to see if there's any genetic linkages. I think that's an area that excites me. But once again, thank you for the opportunity.
Thank you very much for that, Dr. Kleynhans. And so let me just quickly check on in the last few minutes of our webinar. We've got approximately 3 to 4 minutes left. There was a question about working at heights. I'm not sure if that question is appropriate by anonymous attendee, and we'd love our colleagues to, as attendees, just to say who they are. And then there's a question with regard to, okay, well, there's another capacity request. Then there's a question by Severani Mudli. What I would like to know is that in the with winter approaching and many of the flu symptoms and COVID-19 symptoms are common, persons being unwell and being requested to stay at home. However, if you want a person to test for COVID-19, the public facilities take too long to provide the results. At the same time, going to a private facility, one can have the result within 24 hours, but it comes at quite a cost, which most people can't afford. If there's any way that the government can assist companies. So it's a general comment, question and comment about access to testing facilities and testing mechanisms, and as well as the speed and cost of that. I'm not sure if any of our colleagues would want to touch on that in terms of your local and African experience with regard to that. And perhaps we could regard this as the last question. It's quite a general question, not very specific to long COVID. I'm not sure if anybody wants to touch on that. Otherwise, we're going to ask Severani Mudli just to share that particular question with us on the email address info@nih.ac.za. That is info@nih.ac.za. You can direct your question there, Severani. And alternatively, if there is a need, you can see on the screen at the moment, not just the email address, but also the hotline number at the bottom in the little green box. So none of our panelists have opted to deal with that particular question. There are a few other general comments there, but I don't think the questions deal specifically with long COVID. Elizabeth Nopale is not just thanking you as presenters for the valuable information being made available during this particular session, but she's also making the comment about the need to assist provinces to implement the plan and the occupational health practitioners to be involved in the research to come up with evidence-based policies and standard operating procedures, SOPs. So there are some general comments that people are making there. So at this point, I need to say thank you very much to all of our presenters. That is Dr. Murray Dryden, a member of the DATCOV hospital surveillance team at the National Institute for Communicable Diseases, the NICD, and also his colleague, the coordinator of the DATCOV hospital surveillance team at the NICD, Dr. Washila Jassat, for presenting on the long COVID global and South African data. And also we look forward to their own research that they're conducting, and hopefully we will find very useful new knowledge being generated there that can support and strengthen the workplace prevention and workplace programs with regard to preparedness to deal with COVID-19 as an ongoing and unfolding challenge in our nation and the workplace. And then thank you very much to Dr. Neil van Tonder, the ER of Occupational Medicine consultant, dealing with the impact of the workplace and the considerations around the Fit to Work certification of people needing to return to work and may having long COVID side effects and issues that they are dealing with. And we in the workplace, all of us part of this webinar, need to inform ourselves in how best to handle the cases when we are presented with the necessary medical evidence and medical reports from the occupational medical practitioners and specialists insofar as long COVID is going to impact some of our employees. And then finally, Dr. William Kleynhans, on the topic of management of COVID-19 in the workplace, designing a workplace program, very practical, and thank you very much for contributing that as an emergency physician. Thanks to all of you for making the time to join us today and sharing your knowledge and information with our attendees. Much appreciated. And then not to forget that we've got quite a number of our occupational medicine section colleagues as part of our group as panelists to answer your questions in the question answer box. And that includes the lead organizer of this particular webinar, Dr. Odette Volmink, Dr. Nompumelelo Ndaba, Buffel, as well as, I think, yeah, Dr. Nkululeko Tunzi, who have contributed to answering the questions. Much appreciated. And then to our team in the IT section of the NIH, always very reliable and supporting us in getting these webinars out successfully and reaching you as the health and safety, occupational health, occupational medicine practitioners in the workplaces within South Africa, and some people who join us beyond the borders of the South Africa, Southern Africa. Thank you very much to Glenn, as well as Rani, Glenn, who has been supporting us today in this particular session. And with that, I conclude this particular webinar. Thank you very much. We will see you at the next webinar, and that webinar would be taking place next week, and it will deal with workplace risk assessment, cleaning, decontamination, storage, and transportation, particularly looking at the chemical aspects of the COVID-19 epidemic within the country, epidemic globally, how the use of chemicals as part of the barriers and control measures need to be handled properly and stored, transported, etc. by us in our workplaces, by those who are manufacturing it in bulk or storing it in bulk. Thank you very much from myself, Ashraf Raycliffe. See you on the next NIH COVID-19 webinar. Goodbye.